So I'm going to start off with 5 unknown cases, and what I'd like for you to do, there'll be 1 slide per case, is to jot down what you think the diagnosis might be. Case number 1, no history is provided, which is like the typical requisition that you get. Case number 2, this was an incidental finding. Case number 3, abdominal pain in a young woman. Case number 4, a 70-year-old male with vague abdominal pain. I should have taken the arrows off just to make it more challenging for you. And last case, 50-year-old woman with sweating and palpitations. Okay, I'm going to start off by showing you a multi-phase CT protocol. And this is a protocol that you might use when you are evaluating for a pancreatic mass. When you're evaluating pancreatitis, typically what's performed is just a routine CT scan of the abdomen and pelvis, but specific for evaluation of pancreatic masses, you do want to scan at different delays following administration of the contrast bolus. So your minimum scan volume will be from the top of the liver down to the level of the third duodenum, standard KV and MA. Slice thickness will vary depending upon the specific multi-detector CT scanner that you have, but typically with a 64 slice it will be at 0.625 millimeters, and for a 4 slice MDCT, thicker slice thickness at 2.5 millimeters. Standard contrast volume is 120 to 150 ml, and a rate of 4 to 5 mLs per second is needed in order to opacify properly the branch vessels. So there are 3 different phases specific for evaluation of pancreatic masses. There's the arterial phase, which occurs 20 to 25 seconds after you start the contrast bolus. And this is a phase that you would use if you're thinking about performing a CTA, or if you're worried about an islet cell tumor, because typically those enhance intensely and rapidly during the arterial phase. The pancreatic, also known as the parenchymal phase, occurs at 40 to 45 seconds, venous phase at 60 to 70 seconds. The reconstructions that are particularly helpful for the pancreas are the curved planar reformations as you trace vessels and the pancreatic duct or the bile duct as it goes through the pancreatic head. So let's start off with pancreatitis. What are some of the etiologies of acute pancreatitis? Well, as you know, the majority are due either to alcohol or cholelithiasis. Other etiologies include hyperlipidemia, various medications, following manipulation of the pancreas, including following ERCP or surgery, various infectious etiologies, and then familial pancreatitis. There is a CT grading scheme of acute pancreatitis that you should know about. This is by Baltazar. Grade A is a completely normal pancreas, but the patient has chemical findings of pancreatitis and has symptoms of pancreatitis, and this occurs in about 10% of cases. Grade B is where you have an enlarged, heterogeneously enhancing gland, but there is no peripancreatic inflammation. Grade C is when there is spread into the peripancreatic space. Grade D, a single fluid collection. Grade E, if you have 2 or more large fluid collections, or the complication of pancreatic or peripancreatic gas. So here's a patient who has mild stranding around the tail of the pancreas. And you can see the gland is mildly enlarged diffusely. And there's a little bit of heterogeneity in the body. And we typically will evaluate patients on CT when they're at a grade C and above. Now here's a patient with, you can see an enlarged pancreatic head, heterogeneously enhancing, and fluid in the peripancreatic area as well as the anterior pararenal space and the perirenal space, so grade E. And ultrasound is not optimal for evaluation of the pancreatic fluid collections, but it does demonstrate, again, the heterogeneous gland. Here are 2 different patients. The first patient has several fluid collections, so clearly a grade E. enhancement of a defined rim. And so these are evolving into pseudocysts. You can see in the second patient with the larger single fluid collection, there are little islands of fat still located within the fluid collection, and this is pathognomonic for pancreatic fluid collections. Some of the complications of acute pancreatitis: pseudocyst, pseudoaneurysm, thrombosis of the splenic or portal vein, infection with abscess formation, necrosis, and hemorrhage. Some of the features of pseudocyst: as you know, it typically takes 4 weeks or more to develop a pseudocyst. There should not be any enhancing internal components, and the density ranges between 0 to 30 Hounsfield units. Rarely, you may see some wall calcifications. In the setting of pancreatitis, the big differential is pseudoaneurysm, and obviously it's a real differential only when you have thrombosis of the pseudoaneurysm, so that it does not enhance following contrast. And be aware, as you know, that pseudocysts, because it contains enzyme-rich fluids, they can dissect through fascial planes and can occur anywhere. So here's a patient with a large pseudocyst located in the head. You can see that there's evidence of chronic pancreatitis superimposed on acute pancreatitis, large amount of ascites, as well as dense calcifications outlining the atrophied pancreatic body and tail. As I mentioned, pseudocysts can occur anywhere, and in this patient, you can see that it has insinuated into the fundal wall of the stomach. Here is a pseudocyst occurring in the liver, and this was a patient who we scanned following an ERCP, and you can see some contrast in the gallbladder, but there's also contrast actually entering this pseudocyst that is developed in the right crus of the diaphragm. And what about this case, where it looks like this could be just a renal cyst? Well, following ERCP, you can see that contrast fills this retrorenal pseudocyst. Be aware for gas collections within pancreatic fluid collections, this makes it a pancreatic abscess. Here's another one. And typically these patients will go to the OR. Okay, this was our unknown case number 1. I'm going to show you a different patient, but with the same diagnosis. And the finding that's similar in both is that bathed within this fluid in the left upper quadrant is a rounded, intensely enhancing structure that enhances similar to the aorta. Here it is in this patient. And this is a pseudoaneurysm of the splenic artery. And in fact, in this first patient, you can actually see the splenic artery entering into the pseudoaneurysm. Here's another patient who has an interesting finding. You can see that we barely can make out the pancreas, large pancreatic fluid collection with a fluid hematocrit level, and this is from a pseudoaneurysm of the gastroduodenal artery, and this is where it would sit. Pancreatic necrosis is an important finding. Obviously, you need to give IV contrast for this, but note the significant increase in morbidity and mortality when necrosis is present, and this is particularly so if you have greater than 30% of the gland that is necrotic. What do you look for? Well, basically, areas of non-enhancement. And so here we have most of the head enhancing, and then an acute cutoff right here, and we could not visualize the body or tail. Here's another patient, enhancement in this part of the head and the uncinate process, and lack of enhancement for the rest of the glands. And here's focal necrosis. Okay, this certainly did not make up 30% of the gland, though. Now, chronic pancreatitis, on the other hand, this represents permanent structural and functional damage of the gland. Most cases are attributed to alcohol rather than to cholelithiasis. There are other etiologies, including hyperlipidemia, hyperparathyroidism, and pancreas disease. A small percentage of patients will develop pancreatic carcinoma. You're quite familiar with the imaging findings of dense calcifications. The pancreas can be atrophied or it can be enlarged focally or diffusely. The double duct sign is classic when you have chronic pancreatitis involving the pancreatic head, and this causes dilatation of the pancreatic duct as well as of the biliary tree. Pseudocysts and pseudoaneurysms, and then venous thrombosis. And this is, densely calcified pancreas shows nicely its position in the abdomen, but very unhelpful is ultrasound, where the calcifications will shadow the entire gland out and you won't be able to evaluate at all. Here's a patient with dilatation of the pancreatic duct, and you can see that the head is actually small and measures 2.5 centimeters. Here's a different patient who also has chronic pancreatitis. You can see the calcifications, and this time the head is actually enlarged at 5.4 centimeters. Densely calcified gland, and here's a string of pseudocysts extending from the tail all the way into the hilum of the spleen. Here's a patient with dilated pancreatic duct and a large stone sitting within the duct proper. Curved planar reformations, as I mentioned, is particularly useful. You can see the dilated duct. Yes, you can see that well, but you can also see areas of stricture. And here's a stricture right here, and here's another one sitting right here. Now, we've known from many studies that have been published that pseudocysts are successfully drained percutaneously the majority of times, particularly when not infected. These are the indications for drainage, percutaneous drainage. If the pseudocyst is of large size, greater than 5 centimeters, or if there is increase in size on serial imaging, if the patient's symptomatic, and this may be from obstruction of the biliary tree or the GI tract, complications tend to occur in about up to 10% of cases and includes infection, bleeding, and then the development of chronic cutaneous fistulas. And here's a patient with clearly a very large pseudocyst, greater than 5 cm for sure, and caused obstruction of the stomach, and this was post-drainage, you can see successfully drained. Okay, let's move on to pancreatic masses. I'm going to speak about 2 congenital anomalies because they can be occasionally mistaken for focal masses. The first one is pancreas divisum, and this is due to failure of fusion of the dorsal and ventral pancreatic buds. So basically, the head of the pancreas is now drained by the duct of Wirsung, and the body and tail of the pancreas is drained by the duct of Santorini. 5% incidence, this is an uncommon cause of recurrent pancreatitis. Now, multi-detector CT may be diagnostic if you're able to see a fat cleft within an enlarged head. That's often a clue that you have pancreas divisum. Or if you use these curved planar reformations, and you can actually trace out the duct of Wirsung and the duct of Santorini. ERCP is the gold standard. So here's a patient with acute pancreatitis, and you can see that there's small pseudocysts already in the tail. Had a history of prior pancreatitis as well, and you can see peripancreatic inflammation. What do you see on ERCP? This is the classic finding for pancreas divisum. You inject the duct of Wirsung through the major papilla, and you see a shortened duct, main duct. However, when you look at the termination, and this is the key, look at the end, you'll see that there are branches that actually come off of this shortened duct. Here again is a patient with pancreas divisum, a truncated duct, but you see normal branching at its tip. In contrast, take a look at this case, where you have a truncated duct and absolutely no branching. And this appearance is the classic finding for pancreatic adenocarcinoma, which starts in the duct and is the reason for causing this appearance. Here's a patient on CT, what you would find for pancreas divisum. Here's the duct of Wirsung and the duct of Santorini. Same patient on a curved planar reformation. You can see that we've traced out the duct of Santorini, has its separate opening here, and the duct of Wirsung is right here. Annular pancreas is the second congenital anomaly that can appear as a focal mass. This is due to a bifid ventral pancreatic bud, and what results is this band of pancreatic tissue that encircles the second duodenum. About half of patients will present in the neonatal period with the classic double bubble sign, but a half of patients will present as adults, typically with periampullary ulcerations and pancreatitis. Now, again, CT may be diagnostic if you're able to trace the duodenum through the head of the pancreas, and ERCP, again, is considered the gold standard. This is what you see. So we've injected the duct of Wirsung, the main duct. The scope is in the second duodenum, and you can see that we opacify a duct that comes around, encircles the second duodenum, and then crosses midline. This is a different patient, same finding, where the duct makes a turn, comes around, encircles the scope, and then crosses midline. What do you see on upper GI is a classic short segment narrowing of the second duodenum. You can see it's fairly symmetrical, and this is the cause. Here's contrast, positive contrast within the second duodenum. Here's the band of pancreatic tissue encircling the duodenum. Now, this is an easy case, right, where we have air bubbles within the second duodenum that nicely outlines it. What about this case? This was our unknown case number 2. And here, you should have been able to see that the duodenum actually enters straight into the head of the pancreas, causing for this hypodense appearing mass in the pancreatic head. Again, your MPRs, multiplanary formats, are actually quite useful to help lay out the duodenum for you as it enters through the pancreatic head. And here again on the coronal, duodenum, pancreas on either side. Now, what about this case? I've shown this case to residents, and they take a look, and you've got an enlarged head, hypodense mass, and they'll say clearly pancreatic adenocarcinoma. Well, when we rescanned this patient and gave some positive contrast, indeed this was actually just the second duodenum, traverses the pancreatic head, annular pancreas. Moving on to pancreatic carcinoma, this is the 5th leading cause of cancer deaths. There are about 30,000 deaths per year, represents 90% of all pancreatic neoplasms. There is an increased incidence in older males. 70% will occur in the head. And in spite of advances in imaging, the 5-year survival has not really changed over the years and is still fairly dismal at less than 5%. And 90% of cases are unresectable at the time of diagnosis. These are the classic features: a hypodense mass, occasionally, meaning in less than 5% of cases, you may actually see an isodense mass. Hypoechoic on ultrasound, the double duct sign, as I mentioned, for chronic pancreatitis when it involves the head. When you have a pancreatic head carcinoma, you can also see the double duct sign. And then atrophy of the pancreas beyond the level of the pancreatic mass itself. So here's a patient with a double duct sign. You can see dilated biliary tree, dilated pancreatic duct, all due to this large pancreatic head mass. Here is a curved planar reformation showing the double duct sign. And again, dilated bile duct, dilated pancreatic duct, all due to this mass sitting in the pancreatic head. And this is the ERCP correlate, where we have a stricture of the distal common bile duct, a stricture of the pancreatic duct in the head, and it's all due to a mass sitting in this area. Classic appearance, where we have a hypodense mass, atrophy of the pancreas beyond the level of the mass, and dilated duct beyond the level of the mass. This is the TNM classification. Be aware that the pancreas does not have a capsule, so there is early extension into the peripancreatic tissues, and often when we see pancreatic CA on CT, we're already into the T2 or the T3 stage where there's extension. These are the criteria for unresectability: a large mass greater than 5 centimeters. If there is extension into adjacent tissues or organs except for the duodenum. Why? Because the duodenum is removed during a Whipple's procedure. If there's evidence of arterial involvement, stenosis, occlusion, or encasement. And then I have plus minus for venous invasion, because depending upon the site that you're at, even if there's evidence of potential involvement of venous structures, some surgeons will still go ahead and resect and perform venous patching. Other criteria: hepatic metastases, distant lymph nodes, and then carcinomatosis. So this is typically what we don't see, or is early stage pancreatic carcinoma. This patient presented early because he had double duct sign. You can see dilated pancreatic duct, dilated biliary tree, and it's all due to this tiny mass sitting in the pancreatic head, and this is resectable. This is more typical, where we have the larger mass. You can see atrophy of the pancreas beyond, and then dilated pancreatic duct beyond the level of the mass. Here's a patient with clear encasement of SMA and SMV by this large hypodense mass. You can see here's the SMA clearly encased. We've lost that nice ring of fat that we typically see around the SMA. Here's a multiplanary format, nicely demonstrates that there's irregular contour to the SMA, clearly invasion of the SMA. And what about this, where we have, you can see portal vein, splenic vein, and really just a string of the SMV, complete attenuation of the SMV by this large pancreatic head mass. Now, there's a sign that you should look for. Occasionally it may be difficult to find the actual pancreatic mass itself. Now, this patient already has liver metastases, but occasionally all that you might see is this soft tissue that tracks along the vessels around the pancreas. It can be around the celiac trunk and branch vessels or around the SMA, and this is called perivascular cuffing, okay, a sign of unresectable pancreatic carcinoma. This is a larger cuff, and you can see more extensive soft tissue encasing the celiac trunk and the branches. This is another sign of unresectability, where we have a mass, and you can see that there's actually tethering of the SMV and the SMA posteriorly, and this is called the teardrop sign. Now, if you can see that if this mass were smaller, if this was the only finding, extension into the adjacent pancreas, it would be resectable. Extension into the adjacent duodenum, because again, the duodenum is resected in a Whipple's procedure, but this patient was deemed unresectable because of the large size of the mass. Here's another sign to look for. It may be occasionally difficult to actually identify the mass in the pancreas, and what you look for is the interrupted duct sign, where we're able to follow this dilated duct, and then it terminates right about here, and then you look a little closer and you see that there is evidence of hypodense mass. This is the interrupted duct sign. Now, pancreatic tail carcinomas, as you know, tend to come to us at a later stage in that it doesn't cause biliary ductal dilatation early on. And again, hypodense mass, these are two different patients in the tail here. And in this patient already has liver metastases. Both patients have liver mets, adenopathy, and this patient actually has portal vein thrombosis as well. I went through the literature and looked at CT sensitivity for diagnosis of pancreatic carcinoma and then determination of resectability. And you can see that although multi-detector CT has high sensitivity for detecting pancreatic carcinoma, it does not do as well for determining resectability. And particularly in the negative predictive value category, you can see that it ranges from about 55% up to 80%. This is a study I'll go through briefly, but basically what it shows is that maximum arterial enhancement actually occurs during the parenchymal phase, and maximum tumor conspicuity for lesion detection is in the parenchymal and venous phase. So the recommendation here is to only perform the arterial phase if you're looking to perform a CT angiography. Differential diagnosis of pancreatic carcinoma includes malignant etiology such as metastasis, islet cell tumor, lymphoma, and then tumor from adjacent organ, as well as benign etiologies including focal fat, focal pancreatitis, and then necrosis. Let's move on to cystic pancreatic tumors. These represent up to 10% of all pancreatic malignancies. And the top 4 that I have listed here are more common, so those are the ones that I'll discuss. We'll start off with microcystic adenoma. These are actually benign. There is a female predominance of 4:1, an older mean age of 65. There's no preference for any one portion of the pancreas. About a third will have calcifications in that classic central stellate scar. Classic teaching is that you have many cysts, and they are smaller. So numbering greater than 6 and measuring less than 2 centimeters in size. When you have a lot of these tiny cysts, can cause for this typical honeycomb appearance. These cysts do contain glycogen, and there is an association of microcystic adenoma with von Hippel-Lindauer syndrome. So on cut section, this is what you see. And remember, in about a third, you'll see the central stellate scar with calcification and then just innumerable tiny cysts. On imaging on CT, you'll see a multicystic lesion. Again, the cysts tend to be smaller and number greater than 6. And here it is on ultrasound. Here's a patient who couldn't have IV contrast, but again, you can see the multicystic nature of this. T2-weighted MR is also very good for diagnosis and demonstrates a cluster of small cysts. Now, this patient has the classic central calcification and scarring, but you can see that the cysts are a little bit larger, but they still measure about 2 centimeters. And when the cysts are very, very small and enhanced, you can see that it gives the lesion an almost semi-solid appearance. But look for this central stellate scar and the calcification. Mucinous cystic neoplasms, these are in the past were called the macrocystic adenomas or adenocarcinomas, are frankly or potentially malignant. There's a higher female predominance of 9:1, lower mean age at 50. There's a preference for the tail. Calcifications, when they occur, tend to be in the periphery, or rim calcifications in 15% of cases. And this time, there are fewer cysts, so numbering less than 6, but they're larger, measuring each greater than 2 centimeters, and obviously they contain mucin. So on cut section, this is what you see, these large cystic lesions with thicker septations in wall. And this is a classic, all right, mucinocystic neoplasm. Large cysts, it can be solitary or multiple with peripheral calcification. And again, large cyst, thick wall enhancement, and there's a little bit of calcification posteriorly. What about solemn papillary epithelial neoplasm, or SAPIN? These are uncommon, considered low-grade malignancy, tends to occur in young women. They appear as large encapsulated solid and cystic lesions and will often contain hemorrhage and necrosis. There is a preference for the pancreatic tail, and the good news, though, is that complete resection is typically curative. So this was our unknown case number 3, and you can see a solid, predominantly solid, but cystic centrally. This was not off of the tail, but this was in a young woman. And again, this was from the AFIP that shows that about 50% occur in the tail, 100% will have hemorrhage, and also look for this fluid debris level in about 20% of cases. On MR, T2-weighted MR, you can see a fluid debris level here in this patient, well encapsulated off the tail, and this is what it looks like on cut section, hemorrhagic encapsulated. Intraductal papillary mucinous tumor, or mucinous ductal ectasia. Now, histologically, this represents a range of etiologies from epithelial hyperplasia all the way to frank carcinoma, mean age of 65 years. There's actually 3 main types. First is the one that affects the main duct. This could be diffusely or segmentally. Branch duct type, which causes sort of a multicystic appearance, and then a combined type. On ERCP, typically what you'll see is a gaping papilla with mucin pouring forth from it, and you may see mural nodules. In terms of differential diagnosis, chronic pancreatitis is in the differential when you have the diffuse type, the main duct type, and cystic tumors for the branch duct type. And this is just a schematic to show you, this is the main duct type, this is the combined duct type, and these two on the bottom are branch duct types with the larger cysts and smaller cysts. And here's an example of the branch duct type, where we have a cluster of small cysts in the head. Note that the branch duct type is less likely to contain malignancy, particularly if they're under 3 centimeters in overall size, and the recommendation is that you can follow these just with imaging. This was our unknown case number 4, a cluster of small cysts sitting in the pancreatic, in the uncinate process. And of course, the differential diagnosis here based on imaging would be microcystic adenoma. Diffuse duct type. Note that these are more likely malignant and that these have to come out. Here's a patient who just has diffuse dilatation of the pancreatic duct, no other findings of chronic pancreatitis, therefore suspect diffuse duct IPMT. ERCP, markedly dilated duct diffusely, right, filling defects, and this is due to either mucin or mural nodules. And here's the dilated ampulla with mucin extruded from it. Differential diagnosis would be chronic pancreatitis, obviously, but then you look for the other supportive findings, both by history and on imaging for chronic pancreatitis. And here's the combined ductal type, where you have the main duct dilated as well as a cluster of cysts, smaller cysts. And again, on MR, where we have a markedly dilated main duct and then clusters of cysts surrounding it. Just briefly, this is to show you that CT does as well as MRCP for detection of IPMT. From this one study, predictors of malignancy included the finding of mural nodules, thick septations, and then more marked dilatation of the main pancreatic duct greater than 10 millimeters. You know, as we scan with 64-slice CT, we're finding more and more of these smaller pancreatic cysts. And from this study, it was found that a benign feature is if the cyst is unilocular, malignant feature is if you see septations. So if this is an incidental finding, you can monitor just by imaging. However, on follow-up imaging, if you see a change in size or morphology, then the patient should be recommended for endoscopic ultrasound and aspiration. And finally, the islet cell tumors, also known as the neuroendocrine tumors. Islet cell tumors, 85% are functional. And I always say that if you have to have an islet cell tumor, insulinoma is the best type to have. These are the most common. Greater than 90% are benign and resectable. They are of small size, typically. Gastrinomas, on the other hand, these are the second most common, but you can see that 60% are malignant. They also tend to be small, and they're associated with ZE, Zollinger-Ellison syndrome. 15% of islet cell tumors are non-functioning. The majority, you can see up to 90%, are actually malignant, and they tend to present at a large size. About a fourth will have calcifications. The typical imaging feature is that these lesions, islet cell tumors in general, tend to enhance intensely and immediately, and this is both on CT and MR. Let me skip over this. This basically just shows that you do need CT with thin sections for proper detection of islet cell tumors. Classic appearance, intensely enhancing small lesion in the pancreatic tail, the typical appearance of an insulinoma, and here's another one. And this was unknown case number 5, a larger lesion sitting in the tail, again, intensely enhancing. Now, what do you think this might be? Clearly it's malignant, pancreatic tail mass, gastronoma. In this last case, where we have a large tail mass, again malignant, we have liver mets, and there's calcification. Remember that in 25% of these, there will be calcification, and this was a non-functioning islet cell tumor. So in summary, in performing pancreatic imaging, you should use optimal CT protocol. Triple phase with the arterial phase is important if you're thinking about doing CTA or if you're specifically looking for an islet cell tumor. Remember that CT has excellent sensitivity for detecting pancreatic carcinoma, but there's still suboptimal accuracy for determining resectability. Know the signature appearance of unresectable pancreatic carcinoma, and obviously know your differential diagnoses.